Hello everyone, Dr. Sayed Kazmi signing in, and today we have got a very interesting topic. We will be talking about X-rays, in particular chest X-rays, and this is not going to be a sort of a generic lecture on how to read X-rays. This is about how to read particular signs in pediatric X-rays when the kids they present with cardiac problems. So to put it in simple words, kids who have got underlying cardiac problems, especially congenital heart problems, if you are lucky, you might come across these signs when you do chest X-rays for them. So let's get started. Okay, so one thing about chest X-rays, when we talk about the chest X-rays in context of pediatric heart diseases, most of the time we use chest X-rays for respiratory problems. But once in a while, we can do it for cardiac reasons as well. Though, remember that chest X-rays, as far as cardiac problems are concerned, they have got very low sensitivity. So low sensitivity means that they can have a lot of false negatives. In other words, if a child has got like congenital heart problems and you do a chest X-ray, many times you will come across that there would be nothing on the X-ray, though the child has got a congenital heart problems. We call it as a false negative. So there are so many false negatives as far as chest X-rays are concerned. So it has got low sensitivity. But if it is positive, then the chances are high that the child has got that particular cardiac disease if you come across particular signs on chest X-ray. In other words, it has got moderately good specificity. So if you get something, then chances are very high that the child has got that underlying cardiac problems. So to put it in simple words, chest X-ray can be a very good initial test if you are suspecting cardiac problems. And if you are lucky, you might come across that scenarios where you will get those classical signs on chest X-rays which are reserved for particular cardiac diseases. So in this lecture, we are focusing on some of those cardiac conditions and their characteristic chest X-ray findings, which you might come across in your pediatric practice. So the first one, we start with pericardial effusion. Now, pericardial effusion is the condition in which there is effusion within the pericardial sac. In other words, there is fluid within the pericardial sac. Now, why there should be fluid in the pericardial sac? Normally, I mean, because the heart is beating, there is a little amount of fluid within the pericardial sac just to lubricate the layers of the pericardium, that is the parietal and the visceral pericardium. But sometimes in certain conditions, like if a child has got pericarditis, that is inflammation of pericardium, and that can occur because of various conditions that can usually happen as a part of generalized inflammatory conditions, connective tissue disorders. So in some of those disorders like the SLEs or some other connective tissue disorders, the pericardium can get inflamed, and when it gets inflamed, it leads to formation of fluid within that cavity, and sometimes this fluid is so much that it can cause constriction or sort of a compression forces on the contraction of the heart, and the heart can go in what we call as heart failure. So pericardial effusion in most of the cases can be because of underlying inflammatory conditions, and these inflammatory conditions can occur because of autoimmune conditions. They can happen in certain types of viral infections. And in developing countries, one of the reasons for pericardial effusion is tuberculosis of the pericardium. So that is, you should also keep it in mind, especially if you are practicing in a developing country setting. So pericardial effusion, as I told you, is a collection of fluid within the pericardial sac. So what it leads to, so the heart looks like, if you look over here, the heart shadow is enlarged. So obviously, if you do the cardiothoracic ratio, that is the ratio of the heart, where it is has got the maximum width, and you divide it by the maximum width of the thoracic cavity, it would always be greater than 60%. So number one, the cardiothoracic ratio would always be increased. The other thing is that characteristically it gives us what we call as a water bottle appearance. So if you have seen those water bottles, like made up of leather or made up of rubber, then you put water in that and it gets stretches at the bottom. So that sort of appearance you can see on the chest X-rays. So if you see a sort of an chest X-ray where you find a lot of congestion. So even if you see, I mean, because of the constriction, because of the compression of this fluid on the heart is not able to pump properly. So when it's not able to pump properly, there will be backward flow into the lungs. So when there is backward flow into the lungs or into the systemic circulation, the lungs would appear very much congested. So you see these lines, these are pulmonary vasculature and it is extending to the periphery of the lung. So the curly B lines, you can see it is going up to the periphery lung. Oh, there are so many. So pulmonary congestion along with water bottle appearance. So water bottle, water bottle is a bottle, a sort of a rubbery bottle which is full of water. Similarly, pericardial effusion is effusion. It's a type of fluid within that bottle, like you can't call a bottle, but it's just like a flask, or you can say it is the cavity, pericardial cavity, in which there is a collection of fluid. So this type of X-ray, which is very much characteristic of pericardial effusion. So whenever you see a water bottle appearance like this with pulmonary congestion, you always think of pericardial effusion. Okay, so let's move on and see the other X-ray. Now, we come across another condition which we call as a box-shaped heart shadow. Now, this very much resembles what we call as like we in the previous lecture we discussed water bottle appearance. So in some cases it can also look like water bottle, but in fact if you look, water bottle was like you had sort of a triangular shaped appearance, but this one is more roughly a box shaped appearance. So if you see like the upper X-ray over here, if you see, if I draw again, the cardiothoracic ratio is quite high. I mean, if you see, this is the maximum diameter of the cardiac shadow, and this is the thoracic one. Again, if you see, it will be just definitely greater than 60%. But then if you see, you can see like it's more like, I mean, some people might say it looks like a boot, and boot is very much characteristic of tetralogy fellow, but it's not like a complete, like a boot would be having a small pedicle. Here you see it's more of a sort of a, an ill-defined box, not completely square, but rhomboid sort of a feature. So, and you can see this is a massive shadow. It's almost like, taking whole of the thoracic cavity, and this is a neonate with such a big shadow of the heart, roughly box-like appearance. And obviously these kids would be cyanotic. So this is very much characteristic of what we call as Epstein anomaly. So in Epstein anomaly, because there is tricuspid atresia and the heart is not properly formed, so there is a huge right atrium, because obviously the blood, because of tricuspid atresia, it's not flowing forward, so the right atrium get massively dilated. So that's on the right side you see a large shadow, and this is because of the right atrial enlargement. Now at the same time, you see that the pulmonary vessel, obviously because in atresia would be very small, and the lungs are usually oligemic, so they're not getting enough blood supply, and when they're not getting enough blood supply, that means that less blood is oxygenated. If less blood is oxygenated, simply means the child would be cyanotic. So a child who is born with cyanosis and the heart is showing a box-shaped appearance, then we call it as Epstein anomaly. And in this case, if you do an ECG, you would see left ventricular hypertrophy, because obviously what happens is that right ventricle is not properly developed, it's not properly working. So there is some form of like shunting at the level of atria. So obviously right atrium, which is getting a lot of blood, that would shunt the blood from right side to the left side into the left atrium and then into the left ventricle. So left ventricle has to do a lot of work. Left ventricle is taking its own blood as well as the blood coming from the right atrium. So it would um, dilate, not only dilate, get hypertrophic. So you will be getting on ECG a left ventricular hypertrophy pattern. So this box-shaped appearance of the cardiac shadow on a chest X-ray, especially a neonatal one, is very much indicative on Epstein anomaly. And one of the reasons that causes Epstein anomaly is use of lithium. And lithium is a drug which is used for bipolar disorder. So women who have been having a history of bipolar depressive disorders, and they are taking lithium as a mood stabilizer and they haven't stopped it during the pregnancy, they can have kids who have got the Epstein anomaly, and they can have severe cyanosis at birth. And if you do a chest X-ray, you would see a box-shaped heart, which means a very massive cardiomegaly. So box-shaped heart, again, remember, if you can't remember that the box shape BS again is part of Epstein anomaly as well, the EBS, Epstein anomaly. So that way you can also remember. So Epstein anomaly is basically a severe tricuspid atresia and improper development of the right ventricle because of the atresia leads to a massive right atrial hypertrophy, and that gives you a box-shaped appearance on the heart. Now, if you look this X-ray over here, I mean, this is an older child. Now, this is a mild Epstein anomaly. So obviously, it doesn't give you the true shape of what you call a box. It's more like a globular. Some people would say egg on a string appearance, which happens in TGA, transposition of the great artery. Some might also say that it looks like the water bottle appearance of pericardial effusion. Now, if that is the case, obviously you would keep these things in the differential diagnosis. So obviously, if this is the shadow and you don't have a history, you can say, well, it looks like an egg on string appearance. So you would consider transposition of the great arteries. Well, fine. Nobody can challenge you on that because obviously it could be one of the differential diagnoses. Number two, it could be pericardial effusion. Again, you never know. It could be one of the reasons, or it could be a mild Epstein anomaly where there is not like true box-like appearance, but because of the milder nature, milder tricuspid atresia, the right atrium is dilated, but it's not massively dilated to give you the very characteristic findings of a box-shaped heart. But again, as I said, these are chest X-rays. Chest X-rays are never read in isolation unless until you have been given it as a spot diagnosis in exam. In normal practice, you would always have the patient in front of you. You have got the history, you have got the your physical examination. So you by this time you have done your chest examination. You know what type of murmurs are there, what has been the history, what are the O2 sats, and if there were any clinchers in the antenatal history. So if you connect all these dots together, then you can reach the diagnosis whether that is a transposition of great artery or whether that is an Epstein anomaly or whether that is pericardial effusion. So anyhow, just to tell you that you can get this sort of a classic picture over here, but sometimes you can get another sort of a milder picture where you can get it confused with other conditions. So if you get it confused, again, as I said, history and physical examination are your arsenal here, and obviously you would correlate it clinically to say what would be the reasons for that. Okay, moving on. Now we talk about the boot-shaped heart. The boot-shaped heart, obviously it looks like the boot of a small baby. So if you see, this is making a shape of a boot. Now this is very characteristic. If this boot-shaped heart is associated with what we call as dark lung fields, in other words, we call it oligemic lung fields. So oligemia means there are not much blood vessels. Normally there you should be seeing like some pulmonary vasculature here and there, but here you can see there are a few pulmonary vasculature around the phyla. Much of the lung shadows are dark. So some people might mistake it like for maybe pneumothorax is there, but then you can see faint lines, so it can't be pneumothorax. And this boot shape, the tip of the boot is because of right ventricular hypertrophy. So whenever there's right ventricular hypertrophy, it would lift the apex up. So the apex is always lifted up. This happens in right ventricular hypertrophy, and right ventricular hypertrophy is one of the four things that occur in tetralogy of Fallot. This oligemic lung field is because of pulmonary stenosis. You know, pulmonary stenosis is another feature, like one of the four things that happens in tetralogy of Fallot when there will be pulmonary stenosis. Stenosis means narrowed pulmonary trunk. So narrow pulmonary means less blood flowing into the lungs. So less blood means obviously less vascular markings. Here you can see on the lower side another tetralogy fell again. Now if you see, this is not very much characteristic boot shape, but nevertheless it gives you a faint appearance of a boot shaped heart. And again, as I said, it could be other things as well, but again if you focus on the lungs, so you see oligemic lung fields. So again, if you get a boot shaped or something that resembles, not if it is not the characteristic boot shape, if you feel like it could be something related to a boot, always look at the lung field. So if you get a boot like a structure with oligemic lung fields, you can swear that this is tetralogy of Fallot unless and until proven otherwise. But again, as I said, history is your sort of companion over here. So if you have taken history and they've got a history of off and on cyanosis, especially when they are playing and they get distress spells and things like that, that's where it goes very much in favor of tetralogy of palate. And obviously, if you do a chest X-ray, in that you might find the characteristic boot-shaped heart. But even if it is not the characteristic boot-shaped heart, it might be something looking like a boot. This is because of right ventricular hypertrophy that lifts the cardiac apex up a bit, because remember, if there is left ventricular hypertrophy, the apex would be displaced outwards, downwards and outwards. But if there is right ventricular hypertrophy, then the apex would be lifted up. So if the apex is lifted up with oligemic lung fields, that is tetralogy effellate. So TOF, tetralogy effellate, is always associated with a boot-shaped heart. Okay, moving on. Now we go to what we call as the characteristic egg on a string appearance. So egg on a string appearance is just like if you have got an egg which is lying on its side. So if you see a chest X-ray in which you have got cardiomegaly, obviously the cardiothoracic ratio is enlarged. And if you draw a line again on the cardiac shadow over here, very much resembles like an egg. And why we call it a string? Like a string is something, if the egg is on a string. Now normally the mediastinum is has got its own bits because of the structures that pass through it. So you've got the trachea bifurcating into two bronchi. Then you, in small kids, you might have the thymus as well, and esophagus and other structures, blood vessels passing through the. But usually, what happens because of severe compressive forces and a lot of blood flow through the lungs, they're very much congested. So because of this congestion, it's like pressurizes the mediastinum. So the mediastinine structure are squashed. So that even if the thymus is there, it gets squashed. Like so, that's why the mediastinum becomes narrow. The narrowing of mediastinum is because of the um, too much expansion or congestion of the lung fields, and that is because of you have got the two parallel circulations moving on, and again life is dependent on some form of shunting between the two systems. So patent ductus arteriosus or an VSD, that is actually maintaining the life, because if it is close to different system, then obviously it's not compatible with life. So the only thing that keeps the child going, even despite with severe cyanosis or reverse cyanosis, where there is more cyanosis in the upper limbs and less in the lower limbs, that is very much characteristic of transposition of the great arteries. And remember, this is one of the most common causes of cyanosis at birth. So along with the congenital diaphragmatic hernia, the other common reason that can cause cyanosis right at the time of birth is transposition of the great arteries. And in that case, if you do chest X-ray, you might get, I'm using the word might because in many cases you might get a normal chest X-ray. And I told you a normal chest X-ray does not exclude this condition because of the low sensitivity of the chest X-rays. Obviously, if you suspect this thing, you have to go for an echocardiography. But as I said, like in some of the settings, if you don't have cardiac bedside echocardiography or things like that, and then in that case, chest X-ray is a good initial test, and it might give you some clues. But even if it is normal, and if you're suspecting those things, then you have to confirm or refute your findings with an echocardiography. So an egg on string appearance, and that string is because of the narrow mediastinum with a congested or like a plethoric lung fields, is associated with transposition of the great arteries. Okay, moving on. Now we talk about the another cause of cyanotic congenital heart disease, and that is total anomalous pulmonary venous drainage. So total anomalous pulmonary venous drainage simply means that if when the blood goes into the lungs through the branches of the pulmonary arteries, then it comes back, it gets oxygenated, and blood comes back into the left side of the heart, into the left atrium through four pulmonary veins. So these four pulmonary veins are supposed to open into the left atrium. Now, sometimes they might not open into the left atrium and they open into the right side of the heart. So they might open into the superior vena cava, they might open into the inferior vena cava, or there might be a mixed one where they would just open two of them might open the superior vena cava, two might open in the inferior vena cava. So Total anomalous pulmonary venous drainage is the name for this term, where the pulmonary veins, instead of opening into the left atrium, would be opening onto the right side of the heart. So either into the right atrium, either into the superior vena cava or inferior vena cava. You know, all these structures, they open into the right atrium. So what would happen? That the oxygenated blood coming into the left side, that is going to the right side. So you have got a cycle where the oxygenated blood is going to the lungs and coming back to the right side of the heart, and the systemic circulation is getting deoxygenated blood. So that is total enormous pulmonary venous drainage. So there are four types, like the supracardiac type. The supracardiac type means that the pulmonary veins open into the superior vena cava. This is one of the most commonest type of almost 55% of the total enormous pulmonary venous drainage cases are of supracardiac type. Around 15-20%, or sometimes some literature also says that up to 25 to 30% are the infracardiac type. So infracardiac type, they open into the inferior vena cava. And remember, most of the infracardiac types are associated with obstruction. So invariably they are associated with obstruction in the venous drainage, though it is rare with the supracardiac type. And then you can have the mixed type as well, where like some might open in the superior vena cava, two might open in the inferior vena cava. So for the superior opening, like where the pulmonary veins open into the superior vena cava, we call the supracardiac type. That gives you the characteristic appearance of a snowman or the figure of eight. So you see, if you look at this X-ray on the left side, so this and this. So this is the enlarged heart, and you can see this actually widening of the mediastinum gives an illusion of a figure of eight, and this is because the pulmonary veins are very much dilated and they are opening into the superior vena cava. So that gives you the snowman appearance. So this, if you get this snowman appearance, this is very much characteristic of the supracardiac variety of total anomalous pulmonary venous drainage or venous return. If it is the infracardiac type, if the pulmonary veins are opening into the inferior vena cava, then you would see a ground glass appearance. So you can see a ground glass appearance, and this is because of the congestion. So can you see as if somebody has taken a glass and they have grounded it? So grounded glass appearance of the thorax. Obviously, if somebody asks you what is the most common cause of ground glass appearance, that is the neonatal respiratory distress syndrome, which occurs in premature babies. But obviously, in this particular case, we are not talking about a premature neonate, but let's say an older child who's got cyanosis at birth or soon after birth, and the sats are low and they are not picking up with oxygen. And then you do a chest X-ray and you find a ground glass appearance. So the ground glass appearance is because of the what we call as the infracardiac variety of the total anomalous pulmonary venous drainage. So the acronym is, remember that snowman is always above and the snowman is actually on the snow, which gives you the ground glass appearance. So remember, if you take the image of a snowman, sitting on a snow where there is snow falling, and snow falling gives you that ground glass appearance. Remember, snowman is on the top and uh, the snow falling on the ground is lower. So the snowman, the figure of eight, is for supracardiac type because it's above, and lower is infracardiac type, which is the ground glass appearance. So that way you can also remember. So a total enormous pulmonary venous drainage, if it is the figure of eight, that is a supracardiac type. If it is of the ground glass appearance, then it is the infracardiac type. But do not forget that the most common cause of the ground glass appearance in a premature neonate with respiratory distress is obviously the neonatal respiratory distress syndrome, which is caused by deficiency of surfactant. So that you should keep it in mind. But otherwise, if that isn't the case, if somebody asks you what is the next common cause of ground glass appearance in a cyanotic child who's not improving on oxygen, you should say the infracardiac variety of total anomalous pulmonary venous drainage. I hope you have understood that. Let's move on to the next X-ray. Now we talk about the partial anomalous pulmonary venous drainage. In the previous slide, we talked about total anomalous pulmonary venous drainage. Total mean that all the four pulmonary veins were opening on the right side of the heart. Now, partial anomalous pulmonary venous drainage means when one or two of these four they open on the right side, while the other two or three they would be opening on the left side. So if either one or more of them opens on the right side with at least one connection in the left atrium, then we call it as partial anomalous pulmonary venous return, venous drainage, things like that. Now, in most of these cases, depending on how many pulmonary veins are connected to the right side of the heart, you might just get a normal cardiac shadow with some pulmonary plethora. That may be the only findings. I mean, it is quite tricky, just like an ASD. But if there is a lot of blood going on the right side, then you can sometimes see a sign which is known as which we call as the scimitar sign. And scimitar is a Turkish word, it's the Turkish word for sword. So it looks like a sword on the right side of the thoracic cavity or on the chest axil. So if you see, this is something which is resembling roughly like a sword. So this is known as the scimitar sign, and scimitar sign can be seen in some of the cases of partial anomalous pulmonary venous return. So in some, not in all cases. Remember, in most of the cases, you might just get pulmonary congestion and nothing else, or a mild like sort of a cardiomegaly. That's it. Usually echo, and it's very tricky. Only the echo can pick it up. But as I said, rarely you might come across a condition in which, depending on the severity of the partial anomalous pulmonary venous return, you might see a scimitar sign. So how to remember scimitar sign if somebody asks you is sort of a sword type of a sign which is always adjacent to the right border of the heart. So if you see something going upward superiorly elongated, sort of a biconvex structure going on the right side of it, this is because of the congestion in one of the veins, and this is known as scimitar sign. Scimitar, remember, means sword. So as in Hindi, they say like sword is for killing someone, and killing someone is sort of a sin, pap, guna. So obviously, pap, if you say so, you can just remember partial anomalous pulmonary return. I mean, so it's not a full acronym, but anyhow, somehow these tricks can help you in remembering the causes of what causes the scimitar signs. Remember, if you are lucky to see a scimitar sign, you can say this is because of partial anomalous pulmonary venous return. Let's move on to the next X-ray. And now we talk about something quite interesting. And if you look at this X-ray, so you can see the heart shadow, some form of heart. And if you see, it is making a sort of a, like, a duck is sitting or a bird is sitting. So it roughly makes like what we call as a sitting duck appearance. So this sitting duck appearance is very much characteristic of what we call as a persistent truncus arteriosus. The truncus arteriosus is simply that instead of aorta and pulmonary trunk arising separately from the left ventricle and right ventricle respectively, there is a single structure arising, and usually when the single structure is arising, there is little demarcation between the left and the right ventricle, so it's always associated with a VSD. So a single trunk arises and the single trunk is then dividing. So this we call as persistent truncus arteriosus, and it's usually associated with cyanosis, which doesn't improve with oxygenation. So one of the cyanotic congenital heart diseases. So you will get a chest X-ray in which you will see a lot of pulmonary congestion, which is called pulmonary plethora. Whole lung, you will see the vascular markings are going off to the periphery, very much whitish shadows in the lungs. This is all because of congestion, and you get a sort of a heart shadow and the mediastinum and the big vessels, giving you an appearance of a sitting duck. So this sitting duck, as you can see here, this is the duck. This is how it is looking on the X-ray. So if you see a sitting duck in a chest X-ray, you can say that this is most probably because of persistent truncus arteriosus. Okay. Now we talk about the coarctation of aorta. Now, coarctation of aorta, usually in neonates, it give you differential blood pressures or differential sort of saturations in different limb, though it can happen in other conditions as well. But if the blood pressure is different in all the four limbs, you can think of coarctation of aorta. Or if there is sort of a delay in the lower pulses, or if the femoral pulses are weak, or if you're not able to palpate them properly, that might be one of the signs that there's coarctation of aorta. So coarctation of aorta can then lead to increased blood pressure later on as well. So usually you might see a figure of 3. So this figure of 3, if you see, like this is the aortic node, then there is a sort of a concavity, and then there is again a convexity. So this is the pre-stenotic dilatation. So where this here is the coarctation, so the area proximal to that is dilated. So we call it the pre-stenotic dilatation. Then you've got this constricted area where there is actual coarctation, and then there is a post stenotic dilatation. So this gives you a sort of a figure of 3. So you can see a sort of a notch, looks like a rough shape of 3. Similarly, if you do a sort of a barium swallow and then you take an X-ray, you might see similarly a sort of a reverse 3 on the barium swallow as well, if you do a chest X-ray after that. And similarly, in advanced cases, if you closely um, zoom into the chest X-ray and you look into the rib, there might be notches on the inferior margins of the rib. So if there are notches on the inferior margins of the ribs, this is because of these are because there are collaterals, like dilated collaterals, and they erode the lower margins of the rib. So this is actually, you can swear that this child has got coarctation of aorta. So coarctation of aorta would give you this sort of a 3 appearance. So 3 over here, reverse 3 on the barium swallow, an X-ray, and then if you zoom into the ribs, you might see this sort of, again, this is a sort of a 3 reverse 3 in a downward position. So this notching on the inferior margins is because of the dilated collateral blood vessels, and it looks like a 3 on the side. So this, whenever you see these 3 like things, okay, the figure of 3 on the chest X-ray, either on the inferior margins of the rib or on the aortic knuckle or on the barium swallow and chest X-ray, after that you can say that this child has got coarctation of aorta. Okay, now we look into the microstenosis. The microstenosis is rare in the developed world, but it's still a problem in the developing countries, especially where the rheumatic fever is still a problem. Rheumatic fever, is caused by post-streptococcal phenomena, and these kids can develop pericarditis, or they can develop like valvular stenosis. So any valve can be affected. Microstenosis is one of the most common valves that are affected. So if the mitral valve is stenosed, the mitral valve is basically the valve between the left, if this is the heart, let's say, and if these are the four chambers, this is the right atrium, left atrium, and that. So mitral valve actually connects left atrium with left ventricle. So if this is stenotic, let's say it becomes stenosed, so what would happen? Blood would not be able to completely flow into the left ventricle. So when it cannot flow completely from the left ventricle, it would accumulate in the left atrium. Now left atrium is not that much constructed, it's going to get dilated. So once it starts getting dilated, it can dilate to an effect, and after that there will be backward pressure in the pulmonary veins, and the pulmonary veins again, then it means backward pressure into the pulmonary vasculature. So the first sign that you usually see in mitral stenosis is what we call antler sign. So the pulmonary vessels, they go up, like there is a cephalad sort of a projection of the pulmonary vessels. Here you can also see this thing going up like this. This is known as the antler sign. So just like, if somebody has got mustache, if I draw, like let's say this is the person, and this is his mustaches, mustaches going up. Like in certain areas in South Asia, people love to have these types of mustaches pointing upward. They consider it as a sign of power and respect. So same thing, if you saw the sign of mustache or antler sign in the chest X-ray with congestion, this is one of the earliest signs that the child is developing mitral stenosis, and this mitral stenosis is causing backward pressure. As the left atrium gets enlarged, it would push the right atrium to the side. So eventually it would grow to the side that you will see this double right border of the heart. So the right side of the heart eventually becomes, see, this is one border, and then you can see another double density. There is little, so there are two. This is because the left atrium is so enlarged that it is pushing the right atrium towards one side. So this is known as the double wall sign, and this is always visible at the right cardiac border, and this means that there is left atrial enlargement. And as the left atrium gets enlarged, the left appendage also gets enlarged, so there is straightening of the left heart border. So left heart border gets straightened. It gets straight. So the first sign will be the antler sign. Antler sign means that there is cephalad congestion of these pulmonary vessels. Remember, normally there is less, even if the vessels are congested, it would be in the mid zones. There is less cephalad congestion. So cephalad congestion is the earliest sign of left atrial enlargement. After that, you might see the straightening of the left side of the heart border, and that is caused by the enlargement of the left atrial appendage. And as it gets enlarged, it can push the right atrium to the side, giving you the double wall sign at the right cardiac border. And obviously, it's associated with severe congestion. And again, you can correlate your findings with your history and examination to make a diagnosis of mitral stenosis. And again, remember, for all these conditions, the confirmative test is echocardiography. And in certain cases, not only echocardiography, you might have to do a cardiac MRI with contrast or without contrast. So again, well, these days the modalities have changed. It's not only echo, we have got advanced techniques as well. But nevertheless, I mean, on bedside, in a district general hospital, chest x-ray can give you a clue, but if chest x-ray, as I told you, not in every case. If you are lucky, you might get these sort of signs, but nevertheless, for bedside, I think the bedside echo is the best modality in trained hands to diagnose most of these problems. Obviously, if there are issues, then there are other modalities as like the cardiac CT or the cardiac MRI. So this was all about a few pathognomonic signs in cardiac X-rays, which you might see if you are lucky and you come across these kids. But nevertheless, as I told you once again, that normal X-rays do not rule out these conditions. So hope you have liked this. I have tried to simplify it with some sort of not mnemonics like, but some form of things by which you makes it easy to refer to these signs and make you understand what could be the reasons or what could be the causes of these signs. So if you have liked this video, thumbs up would be fantastic. And for those of you who haven't subscribed to my channel, friends, what are you waiting for? Okay, come on, subscribe it. It helps. It gives me motivation to make further videos for you guys. And if you have got special requests, like if you want to have lecture on something special, then please feel free to put your request down in the comment section below. Thank you very much. Have a good day and bye bye.